Dr. Fraser, you're a specialist in longevity medicine, among other things. Do you have any special interests in this area?
Very much so. Probably my biggest area of interest is in individuals who have ApoE4s who are at enhanced risk of developing late Alzheimer's disease. And by that, we mean in the late 60s and in through their 70s, typically 10 years or more before people that don't have this genetic variant. Easy to check for this variant. Other areas of interest relate to optimizing primary care, not doing what current primary care physicians do, which is typically going by the guidelines, which unfortunately lead to the average man, for example, dying at 76.1 years of age in the United States. So doing better than that and optimizing is a big focus around all the things with heart disease and with blood pressure and with insulin sensitivity, and just doing a really good job at primary care is a big focus also.
Dr. Fraser, please discuss the framework of your approach to longevity medicine.
I think the framework is very much around things that are going to harm or disable people and going through those methodically first before getting on to any of the speculative or clever items. For example, we would first want to look at coronary artery disease and then things like malignancy, things like stroke, things like sarcopenia, and go through and sort out how we would avoid that happening to you and do that in an evidence-based way. And then later on, sometimes we will look at some speculative therapies, other things that may not be standard therapies that don't have as much evidence.
Can you discuss proven versus speculative treatments?
Sure. I think an example of a proven treatment would be lowering blood cholesterol in order to decrease your chance of stroke or heart attack. I don't think that there's a lot of speculation involved in that. There's lots of data from double-blind, placebo-controlled trials. Speculative therapy, for example, would be one where we think that you might diminish your rate of Alzheimer's disease by being on a GLP-1, rapamycin, SGLT2 inhibitor, such as Farxiga or Jardiance. These have significant evidence, but we do not have definitive evidence for them.
Dr. Fraser, how do you decide if a speculative treatment should be offered to a patient?
I think that it is an issue of collaboration and discussion in both yourself and the patient, looking at the evidence and also looking at the risk-benefit. So, for example, taking an SGLT2 inhibitor, we go, it's probably going to diminish your rate of coronary artery disease. It may reduce your rate of getting fatty liver disease or getting kidney failure, for example, or getting Alzheimer's. And what are the risks of taking it, including costs and side effects? And I think it is that collaboration and discussion around just an open discussion of what we know and what we don't know, and then sorting out what we actually do, very much in line with patient preferences.